Okay, thank you so much.
I'm sorry, we started the live streaming. I'm not getting the message that we've started live streaming. Thank you.
Okay, shall we go? So, good morning, everybody. Welcome to the compliance.
This conference will now be recorded.
There we go. Good morning, everybody, and welcome to the November 10th, 2020 Compliance Committee meeting. We'll start with the following members present. Mr. Giacalone.
Here.
Myself, Michael Schottenstein, and Dr. Bechtel has been appointed for the morning for a temporary appointment to the Compliance Committee.
Present.
Thank you. So I know we're going to be approving minutes later in the day. Do we have any minutes to approve this morning?
No, this is Benton. The last meeting minutes were approved with a full board last month.
Okay, that's what I thought. Thank you so much. So Stephanie, do you want to go ahead and start us off, please?
Sure. Thank you. Good morning, everyone. So today we have Kelly Long here from the Ohio PHP, and we invited Kelly back. Kelly did our presentation at the retreat, and we had such a nice discussion. We really didn't make it through the conclusion of Kelly's presentation. So she has graciously offered to be here today with us. And I'll point out she's even on vacation this week, but she offered to be here with us today to sort of walk through the end of her presentation, which really included two different scenarios for us. So we can really understand how a probationer or and a licensee moves through the OPHP system in two different scenarios. We didn't get a chance to talk about those scenarios. We thought it would be helpful for context, and you'll have to harken back to Kelly's presentation to sort of pick up the thread. But really, we just want to give you that example. And then, of course, Kelly, if you have anything else that you want to talk about today, if we have time, that's great. But take it away.
Great. Well, thank you so much. I just want to make sure everyone can hear me okay. Okay, great. I was on a meeting yesterday and I definitely was getting no's instead. So I'm glad Tuesday is a little better for me. So, well, good morning. Thank you for having me back. Thank you for that intro. And yeah, like Stephanie said, really just wanted to tie out the presentation from the retreat. We covered a lot of information during that discussion. It was very process, very procedural based, and we covered pretty much the 5 requirements. So going to that evaluation, completing treatment as recommended for a substance use disorder, suspending practice for 30 days, and what the process looks like to be cleared to return to work, that continuing care requirement and what's involved, and then lastly, the monitoring agreement, which has all those monitoring components. So I thought it would be helpful just to use a couple of case examples to show how it works in application rather than just in process. So excuse me, the first case I have is sort of the ideal scenario. If everything is working the way it should work, this is sort of the process. So this is a de-identified case. So we received a call from a residency program director who expressed concerns about his resident. The resident reported to him he received a DUI over the weekend from a party that he had attended. So we talked to the program director, gathered a little bit of information, and then we just asked the director to have that actual practitioner call us. So he called our program, spoke with our clinical director. We did some general intake information, and just based on what we were able to gather, he sort of self-recognized he needed help with his alcohol use. So he agreed, instead of starting with an evaluation, going into treatment, the resident was agreeable just to enter straight into a residential level of care at a treatment provider. So again, this is sort of ideal scenario, someone who recognizes they need help, is agreeable to seek help, and then someone who's motivated to go to treatment. So we do like a preliminary determination when we first get that phone call to determine whether or not the practitioner is eligible for the program. So had a substance use disorder, was never in the program previously, didn't have any disciplinary action on their license. So we assisted the practitioner in getting into treatment at a board-approved provider. Just kind of as a side note, even though the practitioner goes straight into treatment, that evaluation piece is done as part of the treatment process. So it is done just not as a separate process. So they're in treatment. We're getting weekly updates on the progress of how they're doing. Right when they're getting ready to discharge, we coordinate for them to enroll in a monitoring agreement. So they're able to do that. They start doing their toxicology testing. Once we get some negative results and we have clearance from their treatment provider, they meet with our medical director and their assigned case manager at OPHP and clear them to go back to work. This specific individual's monitoring contract had attendance at a minimum of 3 support group meetings per week, completion of 3 to 4 urine drug screens per month, quarterly reports to be submitted by his therapist, monthly reports to be submitted to OPHP by their continuing care provider, quarterly reports from their monitor, who he identified as his program director, and then required to meet quarterly with their OPHP assigned case manager. So this is an individual in our program. We've had no incidents to date. Like I said, ideal scenario. So next up, we have process-wise a little bit different. So this is an individual, an osteopathic physician that we received in a report from the medical board as being potentially impaired.
Hey, Kelly.
Yes, sorry.
I think Mr. Giacalone has a question.
Yeah, can I ask before you move on to the next one? In this first case, the individual was impaired, had a relapse, and then he went into the program. Maybe I misheard you, or was this?
No, this was just someone who had a DUI, so it was first time.
The first time. Yes. Okay, never mind. Sorry, I'll just for clarification. No problem. Thank you.
Great. Yeah. Were there any other questions? I'm sorry, I just kind of dove right in there.
I have one actually, if you'd be so kind, since we took a minute. Did this person go in under the 1 bite?
Yes.
Okay, just double checking that. Thanks.
Yes. Great. Okay, so next practitioner, osteopathic physician referred based on a disclosure to the medical board, was reported back out to OPHP as potentially impaired due to a substance use disorder. So we reached out to that practitioner. They completed that initial intake, same process, gathering information. They were agreeable to go to a 72-hour evaluation at a 1 bite program approved provider. During that evaluation, they were diagnosed with an alcohol use disorder and recommended for residential treatment. So the practitioner was agreeable to enter treatment. We provided them with a list of providers or facilities that they could go to, completed treatment, had no real issue, were doing well. The sort of same process for return to work. Their treatment provider cleared them to work. The practitioner met with our medical director, was cleared to return to work. And 1 year into their monitoring, the participant self-disclosed during one of those case manager meetings that they had relapsed on alcohol. So this was not an instance where we had a positive toxicology test result or an incident reported. This was just a self-disclosure. So when that happens, our clinical team, sort of all hands on deck, works with the practitioner to re-enter treatment. We like to see it the next day or same day if possible. A report was issued for a relapse to the medical board within 72 hours. And though, even though that report is made and they're not technically in One Bite any longer, OPHP still continues to get progress updates on their treatment to make sure that they're doing well, not being discharged AMA. And then in the event that there's not finalized either consent agreement or action by the board when they complete treatment, we do ask that the practitioner re-enroll in monitoring with OPHP until those conditions are established with the board. So just kind of two totally different scenarios. Yes, I see some hands. Oh, I think you're muted.
Eddie, you're on mute.
What does AMA mean? Or did I miss?
Against medical advice or staff advice. Yeah, so if they left treatment and they weren't successfully discharged.
And then you maintain, you try to get some kind of maintenance of oversight until the handoff happens to the medical board. Wonderful.
Right. Ideal scenario, yeah.
And does that have to be done? That's done obviously with consent of the physician or the. Okay.
Yes, ma'am. Yeah.
I've got one other question. Is there any kind of issue? Are you only dealing with substance abuse? And do you deal with, for example, sexual related matters, or is it only alcohol, drug, substance stuff?
So the One Bite program is explicitly for substance use disorder.
Okay.
And I think Stephanie has mentioned this previously. So a few years ago, OPHP actually implemented in our program guidelines that if there's a disclosure of any sexual misconduct as part of that,
Yes.
that is something that we would report.
Okay. All right. That was the question. Thank you.
So any other questions? So those are sort of just two different scenarios. Yes.
Hi, Kelly. Thanks so much for being here. So just on that note from Betty's question, other than sexual misconduct that is disclosed, do you report other infractions as well that are disclosed that way?
Do you, outside of sexual misconduct?
Yeah, in other words, you're monitoring the licensee for substance use disorder.
Mm-hmm.
There is information that comes your way that there have been additional infractions. I guess what I'm asking is, even leaving aside sexual misconduct, if you want other infractions as well, can you report those too?
I mean, I would imagine, I don't know that we've had many instances of that. I actually can only think of one instance of sexual misconduct that we reported. But yeah, if it fell outside the scope of a substance use disorder, we would be required to report like any other physician requirement. Mm-hmm.
Okay, thanks so much.
Just to clarify Michael's point, we're talking about like domestic violence, aggravated assault, that kind of stuff. I mean, it's
Yes.
not necessarily, somebody who's drunk, that's a possibility, right?
Yeah, that's a great question. So all of our staff, most of our staff are licensed professionals, so they would all have reporting requirements for things like that. So yes.
Okay, thank you.
Mm-hmm.
Great. Any other questions for Kelly?
Well, I guess I'll just make another point, which is this sort of speaks to that memo that you sent us a little while ago about the reporting requirement of the medical director, right? So this is sort of what we're circling back to, it sounds like. Right, okay. All right, thank you so much.
Yeah. Betty?
I really want to know the name of your dog, so.
Oh, I realized at the last second that he was in here, and I was like, please don't let anyone knock on the door. This is Boomer. He's a golden doodle. I don't know if you can see him.
Yes.
I'm in the wrong direction. Okay.
Sorry, it's not.
Yeah.
Great.
So if there's any other not any other questions about the cases, I actually have just two last pieces. One is to review sort of year one of the data for the One Bite program. So if you'll remember, the One Bite program was updated in statute in January of 2018. The rules were enacted in February of 2019. OPHP was selected as the monitoring organization in May. Of sort of year one, May to May. So we submit updates quarterly to the board. And this is just sort of a consolidated 1 year's worth. So in the first year, we received 121 referrals. Most of those were physicians or resident physicians. So they made up about, I think, 80% of those referrals. We did see quite a few massage therapist and respiratory care professional referrals, as well as physician assistants. And then we saw kind of a trickling in of a couple dietitians and acupuncturist and anesthesiologist assistants. So from those referrals, 55 practitioners at the time of this report were enrolled in a One Bite program monitoring contract. And in the first year, there were 31 reports issued from OPHP to the medical board, ranging from someone being ineligible for the program, someone relapsing and no longer being eligible, or people just declining the offer to seek eligibility for the One Bite program. So we issued in the first year, part of what the monitoring organization also does is provide training to the treatment providers. That's one of the things we found to be most helpful. We offer online monthly trainings to anyone who's approved to provide any level of care for the One Bite program. And what we've seen we track in these reports, we track treatment. We're tracking length of stay, type of level of care. So are they in residential, PHP, outpatient treatment, etc. And what we've seen is the actual acute treatment duration is a little bit longer than what we've seen in the past. So the average length of stay in either a residential or partial hospitalization setting is about 45 days. And I would say within the last 6 to 8 months, what we've seen is a large increase in sort of the extension of treatment. So you have most intensive is residential or partial hospitalization, and then you have sort of a step down for intensive outpatient treatment, which is typically just multiple days a week for a few hours a day. And we've seen a large influx in treatment providers utilizing that extended treatment. So that's not something we've experienced before. And just outside of the year one, something that we did implement a few months ago, which I think has been really helpful just from a transparency standpoint, is we implemented a monthly meeting. It's Stephanie, Jill, Alexander, and myself, and it's really just to review activity. What reports did we send? What reports did we receive? Are there any issues? Are there compliance concerns? That type of thing. So I think that will continue to be really helpful.
Yeah, that's been a good, it's given us the opportunity, I think, to not only just learn the program a little bit better, but to sort of, when you have any new program, what we keep saying is, as we operationalize this, we have to find what we didn't imagine or envision happening. And after our last monthly meeting that we just had, I guess that was 2 weeks ago, Kelly, right? 2 weeks ago, maybe. Mm-hmm. We talked about really what it's time to do is sit down and do a good process map of everything that as it's coming in, how we're working through the system, where do we have holes, where can, where can we shore some things up, I think along the way, but in some, I think those are really good numbers for a first year program. And we've already made some basic program operation changes along the way that are helping.
May I ask a question?
You may.
Please.
You've got 121 referrals. with only 55 practitioners enrolled and 31 reports to the medical board, which I assume are folks who have refused to enroll. Where are the rest of those numbers? Because it doesn't add up to 121.
Sure. So not all of those reports are from the medical board. So the 121 represents as a total in whole. And some of those individuals would have completed the evaluation and not received a diagnosis. So the One Bite program is not really applicable to them. That was probably a large chunk of individuals. And that's actually something that Stephanie and I have been talking about, at least related to the board's referrals. How do we tighten that up as far as communication back and forth to make sure when those referrals happen that they're communicated back to the board if there's no diagnosis made.
Okay, I'm sorry. I'll have to walk back because I don't work through all your processes. I'm not familiar with them, but they're referrals from all sorts of reporters to you.
Could be from a spouse.
That there's a problem.
Mm-hmm.
Some of them, you say, they come back without a diagnosis, meaning you've had them go through a process of evaluation and it comes back no substance abuse problem.
Correct.
So that's still a significant number of cases that people are spending a great deal. Not that, I mean, it's not cheap to do the evaluations. Yeah, that's significant. It looks like a lot of number of practitioners that were sending for evaluation that don't need that they come back without a. Is that? Am I reaching the conclusion there, Kim?
Kelly, what do you think about that? Do you feel like you're getting a lot of people who are not getting that impairment diagnosis?
I would think that's a fair assessment. I think in the first year, we saw that significantly more than we see it now. And I'm not really sure the rationale for that. I think a lot of times, an instance, like if a practitioner gets a DUI, there's a high probability when they renew that they're going to have to get that evaluation anyway. So sometimes they'll just proactively do it. And I think that's most commonly where we see someone completing evaluation and not receiving a diagnosis of a substance use disorder are related to those isolated DUI instances. So yeah, but I think your deduction of that is correct. I would say these reports are a little bit tricky because you would see the 121 referrals and 55 in the program, but there's probably a portion of people that are in treatment that haven't signed an agreement yet. So there's a little bit of that as well. So people in treatment not being monitored yet, as well as the population of people that have completed the evaluation and not received a diagnosis.
All I can say is, Kelly, it's so impressive that you are hanging on to people that you are troubled by till we can get a hook on them. And it's just very impressive and very responsible.
I appreciate that. Yeah, it's we feel connected to the individuals, so we just feel like it's the right thing to do, kind of across the board, both for patient safety and to help the practitioner stay motivated and make sure that the folks are doing the treatment that they should be. So, is there any other? Yeah.
Okay, Kelly. A couple of questions. You mentioned that you have monthly meetings with providers for training. Did I hear that correctly? Is that a required meeting with the provider? Is that an optional meeting? And how is that done?
So Kim would have to correct me. There is a rule requirement that treatment providers have, I believe it's quarterly training about the board statutes, rules, and policies related to the One Bite program. And so we don't we don't have any sort of say in who attends when. We just sort of publish. We've been doing it 6 months at a time, so people can go in and register. But we have, I mean, we're talking to treatment centers probably every day. And so we have a pretty good sense of who's attending these programs. Usually when a treatment center first becomes approved, we'll do a pretty intensive training with their clinical team. We do a couple few hour sessions where we'll have just maybe the executive team in, and then we'll bring in their whole clinical team so they sort of understand the requirements. We also have brochures that are practitioner based and treatment center based that are more like cheat sheets of like, here's the one bite if you're a practitioner and what you need to expect. If you're a treatment provider, here's the one bite and here are all of the things that you need to be doing.
Okay. And the other question I had is, you talked about on average, I think it was inpatient is 45 days. Mm-hmm. Intensive outpatient, is there a number for that?
So we haven't tracked it. I guess I didn't average it for that first year, but we could. Your standard outpatient treatment programming is 4 to 8 weeks.
Okay, I'm just curious.
Yeah.
No need to calculation. Thanks.
Yeah. Mm-hmm.
So Kelly, we're actually bumping up against policy now. So grateful for everything you've had to say today. Was there anything else you wanted to run by us that we haven't covered yet?
Sure. I'll take 2 minutes if I can to just sort of close about what we saw and from a clinical entity, possible considerations from the board. We get a lot of phone calls from practitioners who are in another state's physician's health program that's looking to get a job in Ohio, and just wanting to take a look at if there's an ability for that transfer to happen under the confidential umbrella. So could someone be in the Pennsylvania physician's health program under their confidential requirement, and could they transition into the One Bite program knowing that they would still be required to do all the things that we talked about during the retreat and today? I think that's one of the things we wanted to offer up as consideration. Another thing was really to look at the information that we can share with one another when it comes to reports of suspected impairments. We don't have any evidence of this, but our gut tells us from the limited information that we're receiving, there's a high probability that people are being misdiagnosed or underdiagnosed, even if you just applied kind of a broad-based statistics for people with substance use disorders. And lastly is, I know we talked about it at the retreat, is maybe taking a look at that definition of relapse, and is there a way to further align it with the different levels of care, so that way it's a more practical application for not just individuals with disciplinary action, but individuals in the One Bite program as well.
That's great, Kelly. And my recollection, Stephanie, too, is that staff is, working on researching the points raised in your memo to us, that, we're touching on again today. So, really grateful, that you are here, and certainly a standing invitation, glad to have you anytime, really.
Yeah, great. Well, thank you so much. It's a pleasure to be here. And I know some of the board members shared kind words about Stephanie at the retreat. And just from a stakeholder perspective, just echoing those comments, she really has been a delight to work with. So yeah, happy to be back anytime. Appreciate it.
Thank you so much, Kelly.
Enjoy your vacation.
Thank you. Thanks, everybody.
All right. She said it just like you told her to, Steph.
Bye, everybody.
Anybody else have any further thoughts? Could I have a motion to adjourn?
So moved.
Dr. Jekyll, Mr. Jekyll, thanks. All in favor? Aye.
Aye.
All right. Pleasure. See y'all soon.
This conference is no longer being recorded.